Welcome to our third edition of EBNEO Journal Club. We're really excited today to talk about red cell transfusions in preemies. And I'm really delighted today to have joining with me Amy Keir, who's from the University of Adelaide in Australia, and she's done a lot of work on neonatal transfusion and really looking forward to her perspectives on some of the studies we're going to talk about. And then Souvik Mitra, who's joined us for a prior EBNEO Journal Club, so we'll be talking a little bit about some of the evidence-based medicine aspects of trials and how they address and also contribute to bias. None of us have any disclosures. So Amy, there's been two trials that have been long awaited that have compared different approaches to red cell transfusion in preterm infants. The transfusion of prematures, or TOP trial, as well as the ETTNO trial that was done in Germany. And these are ones that we've recently highlighted. The TOP trial was published just at the end of last year, the ETTNO trial a few months prior to that. And I wonder if you could walk us through these trials, and maybe we could start with the TOP trial and tell us what these trials found.
Thank you very much, Ravi, for inviting me along today to discuss one of my favorite topics in neonatal research. So as you say, we've all been waiting with bated breath to get the results from the ETTNO and the TOP trial, and it was exciting to see the TOP trial published on New Year's Eve of 2020. And the main findings from the TOP trial, I guess the bite-sized thing is that there was no difference found between the liberal and transfusion threshold groups in regards to the group's primary outcome, which was a composite outcome of mortality and neurodevelopmental impairment at 22 to 26 months of corrected age. So that's basically what they found. They also went through and looked at the different composites of the primary outcome, as well as a whole host of secondary outcomes. And for the TOP trial, no difference were found between either of the treatment groups in regards to any of their composite outcome and any of the composites of that outcome, as well as all of their secondary outcomes. So in some ways, that's obviously reassuring for people out there who have been already using the lower transfusion thresholds, although not everyone has been doing that. And it will be quite interesting to see how the findings of the TOP trial in combination with the ETTNO trial, which basically showed the same, that there was no difference between outcomes in regards to transfusion thresholds, to see what the neonatal community takes away from these trials and how and if it influences practice.
Thanks for that summary. Coming into these trials, there were a number of observational studies that suggested potential harm from red cell transfusion, with potential associations with necrotizing enterocolitis, bronchopulmonary dysplasia, interventricular hemorrhage, and you kind of touched on some of these secondary outcomes. What did these studies show regarding these specific outcomes?
For the ETTNO trial, there were no differences in any of those secondary outcomes, which did include necrotizing enterocolitis. So that was certainly of great reassurance. And again, with the TOP trial, they did not find any difference in the whole host of secondary outcomes, which did include NEC, Bell stage 2 or 3.
So Amy, out of all the secondary outcomes, were there any differences observed in any of the trials?
So across both of the trials, there was only one difference in one of the secondary outcomes, and that was for the ETTNO trial. They actually found a difference in weight of the baby at 36 weeks of postmenstrual age. So in the the liberal transfusion group, the weight was on average 2,113 grams versus 2,068 grams. So although it was statistically significant, whether that was clinically significant is difficult to know, but it is worth noting that there was one difference out of all of the outcomes that were looked at, for those that read these things very carefully.
Thanks, Amy, for that excellent summary. And so I wanted to bring in Souvik here and talk a little bit about what you touched on, which is the differences between the observational studies and the lack of any difference in these trials, and potentially bias, and how these large trials and randomized trials in general might reduce bias, confounding biases that impact observational studies. And also potentially, as you think about these trials themselves, potential sources of bias in these trials. And so, Souvik, I wonder if you can touch on both of those aspects.
Thanks, Ravi. Now, comparing the effectiveness of two interventions is very, very common in neonatal medicine. The most important thing that underlines the trustworthiness of the comparison is whether the two groups being compared were prognostically similar before being exposed to the respective interventions. So that if they had not been exposed to the interventions, they would have had a similar distribution of clinical outcomes. Now, when we make such comparisons in observational studies, then in spite of our best efforts, we cannot ensure this prognostic balance because the need for one intervention versus the other will be dictated by the baseline risk factors, and this creates a selection bias. Now, the same risk factors that affected your clinical decision to select a treatment may also affect the outcome, thereby introducing what we call confounding by indication. And this is a very common problem in observational studies. Now, the reason why randomized trials are so highly regarded in the world of studies is due to this powerful process called randomization. Because when it is properly executed in a large number of subjects, we can be fairly certain that it eliminates selection bias by balancing known and unknown prognostic factors between the two groups being studied. So hypothetically, if both groups received the same intervention, they would have had a very similar distribution of clinical outcomes. So when we randomize infants to different interventions and get a different distribution of clinical outcomes, we are again fairly certain that these observed differences were due to the different effects of the two interventions. Now, we can be even more certain that the observed differences are only caused by the interventions themselves if the prognostic balance is maintained after randomization. But it is always not feasible to do randomized trials under such ideal experimental conditions. And bias may creep in after randomization. Now, this post-randomization bias can creep in either consciously or unconsciously. For example, in unblinded studies, caregivers may consciously introduce a proven effective co-intervention to make a desirable intervention look better. And we are all aware of this bias, and we usually talk about this in journal clubs. But post-randomization bias can also creep in unconsciously in studies where the primary outcome is a long-term follow-up outcome such as neurodevelopment. Now, this might happen when a well-intentioned caregiver unconsciously introduces a co-intervention to mitigate any short-term effect that was perceived as harmful. So the worst intervention now does not look so bad at the end due to the mitigating effect of this post-randomization co-intervention. Now, this effect, also known as the post-randomization confounding, has been discussed in further detail in a 2016 JAMA viewpoint by Manson. Now, another source of post-randomization bias is loss to follow-up. Now, if the losses are in large numbers and the losses are different in terms of their proportion, timing, reasons between the two groups, it might well be that the losses were related to a certain outcome or a fallout of the intervention. And such losses to follow-up may again introduce bias, as we have now lost that prognostic balance between the two groups.
Thanks, Souvik, really for the nice summary. And kind of as we think about biases, it's always important to consider these systematically when we're evaluating evidence. So coming back to Amy, what do you think in terms of these three aspects of baseline imbalance, post-randomization bias, and loss to follow-up as it might impact these two trials that we discussed?
So in regards to imbalance between the two treatment groups in both trials, when you look at both of them, there don't appear to be any imbalance between the two treatment groups, and they're both well-designed RCTs, and you wouldn't actually generally expect to see a baseline imbalance when designed correctly, which they were. So that is reassuring. In regards to loss to follow-up, both of them had very high follow-up rates. So both trials followed up over 90% of the infants that were able to follow up to the primary outcome, at least for both treatment groups in both trials. Interestingly, with the transfusion of prematures trial, one of the exclusion criteria were family was to exclude a baby was if the family was unlikely to come to follow up. So that sort of set a few alarm bells off for me. But when you actually go back and look at how many families, that was only 120 infants out of the 4,915 that were initially deemed eligible. So not a huge proportion, but I guess an interesting take on that. For the TOP trial, but it both had very high follow-up rates, over 90%, which I think most people would say is about the best that you can aim for in the RCT setting.
Thanks. I'd like to move on a little bit now to kind of how these trials are going to impact practice. And this is a recent poll that was posted on Twitter to the neo-AVM community in terms of these findings and what is likely to change regarding hemoglobin transfusion thresholds. And you can kind of see these results here, and there was a mix of responses. So I wonder, from your standpoint, in light of these two new trials, how are you going to change your practice, or what do you think might be changes that occur in the way preterm infants are transfused?
I think for our practice here in Adelaide, this has confirmed the lower transfusion threshold. So that's where we were already tending to practice. But I think this is reassuring that at the very least for infants who are 48 hours, 72 hours of age or older, that following the lower transfusion thresholds described in both of these trials, certainly now has, I believe, the evidence base to support that this is safe, appropriate practice for this cohort of infants. I know I've had colleagues that have had anxieties around that first 24, 48, 72 hours about whether or not we need a different approach aside from a hemoglobin or hematocrit level. And it'll be interesting to see what other work comes out of these trials, because Ravi, you've mentioned previously in discussions that there's a few nested studies that will come out. So that'll be very interesting to see what other work comes out. But I'm hoping that this will encourage the neonatal community to move towards lower transfusion thresholds for neonates.
And a couple of comments we saw on Twitter regarding when we posted this was, can we go lower than the threshold studied in these trials? What do you think about that? About, is there a need to even test lower thresholds?
I think that's a very important and interesting question. I think it's challenging to answer in that we know those transfusion thresholds out once they're 3, 4, 5 weeks of age. They're sort of getting to the lower transfusion thresholds that we see in other patient cohorts. So it would be pushing the envelope, but it's certainly a question I think that's worth considering, especially for those convalescing babies further out. But I guess if you ask around letting a baby go lower than 7 or 70, or the hematocrit version, depending on what you follow, I think people would be starting to get a bit nervous. And you could see in the different groups in the trials around protocol violations, it was more likely to happen in the lower transfusion threshold group. So I'm not sure from a pragmatic perspective whether it would be feasible, but still an important question.
Thanks for that summary and for joining us, both to you, Amy, and as well to Souvik, for a topic that I know is near and dear to many of our hearts about transfusions, and really delighted to be able to highlight these two trials and put the evidence into context. So thanks for joining us today.
Thanks, Ravi.
Thanks, Ravi.
And thank you all for joining EBNEO Journal Club, and stay tuned. We hope to have another episode coming to you next month.